The idea of today's lecture is to reduce the fears and increase the radiographer's confidence when performing the study. It's always drummed into us, obviously, not to x-ray pregnant patients, so that makes a few people nervous, especially if you haven't done many. And obviously, if we're nervous, we're going to make the patients nervous about having the study performed. It's just common sense. Obviously, you know, I've done my masters in that since I used to work here, so this was one of the topics that I studied. So the objective of today's talk is to review the most appropriate protocol alterations for the physiological changes observed during pregnancy. Obviously, we want to reduce the maternal and fetal dose while maintaining diagnostic image quality. An interesting thing regarding this is that only 40% of departments alter their protocol for a pregnant patient, and that only 16% have actual written policy regarding this. So here's a background. So as a lot of us know, you're more likely to get a PE if you're pregnant, and it's actually the leading cause of maternal death in the developed world. It's 4 times more likely in the pregnant than general population. A clinical diagnosis is often impossible because they have physiological changes observed during pregnancy often mimic the signs of PE, like preeclampsia, etc. Also interesting is that the incidence of PE increases each trimester. So it's 20% in the first trimester, 32% in the second, and 48% in the third. So you're more likely to have a PE in your third trimester, which isn't good for us because that's when you're going to get your most dose from your CT. But that's just the way it goes. Western Australia does have a very good imaging pathway that's sort of a state-based thing, determining what imaging should be done in which order and which scan you should do. A lot of people will say, I've even seen a lot of radiographers go, oh no, VQ scan, because they're just a bit worried that they might stuff it up, even though, or they might think the dose is less with a VQ when it actually isn't. So, you know, that's a common misconception. So once physicians have used the primary diagnostic pathways, which is what Western Australia set out, all journal articles will tell you the same thing. They should have a DVT ultrasound, a D-dimer, and a chest x-ray performed. Obviously, you know, we can rule out a few things that might be mimicking the signs of a PE, like a pneumothorax, pneumonia, pleural effusion, pulmonary edema. You know, that can give you that pleuric chest pain. You can be a bit short of breath, etc. from all those conditions. So the chest x-ray will rule those out. And if you were in a department where your protocol was to do a VQ scan or maybe perform a VQ if you had nuke med on site, that will allow you to differentiate if you can actually do that VQ study, because if there's pathology in the chest, you're going to get an intermittent scan on your VQ scan, so they're going to go for a Ctpa anyway. So you're giving them a lot of dose. I know this isn't talking about VQ, but I also remember reading a lot of articles regarding VQ. There's methods that they can reduce the dose, such as voiding the bladder, only doing perfusion, not ventilation, etc. But the chest x-ray, if there's some sort of underlying pathology, like, you know, there's heaps of things, as I said, pulmonary edema, pneumonia, it's all going to give you, the VQs are high, intermittent or low probability. They never give you a definite answer, so it's no point doing it. So nowadays, multi-detector Ctpa is regarded as the reference standard, so that's the thing that we should be doing. It's got a high sensitivity of 94%, specificity of 100, and a negative predictive value of 99%, so they're great numbers. You can't really expect too much better than that, but I must tell you that it has to be a diagnostic study with a cardiothoracic radiologist reporting them to get those sort of numbers. D-dimer is controversial with a lot of clinicians because it's going to be positive in a lot of instances because pregnancy increases the D-dimer, and it depends on the assay and cutoff values used. A lot of studies still recommend using D-dimer because it has a high negative predictive value. It's not going to cost anything to do this study to get this result because they're doing bloods for them anyway for the renal function, etc. And it does have a low positive predictive value. So of all the studies, I think I read 32 studies I decided to include in this talk, which was quite substantial. All of them say that 50% of the D-dimer will be normal in your first trimester of pregnancy. So if it is in your first trimester and it is negative D-dimer, you don't have to do the Ctpa. another important thing with the DVT ultrasound is that the studies showed that you're 3 times more likely to have a DVT than a PE. So if you've got the DVT, they can just treat without subjecting the patient to radiation. Obviously, as we know, ultrasound doesn't use radiation. So as radiographers, you know, all that other stuff sort of to do with the doctors ordering examinations, what do we do? So first we must check that the CT's been approved by the radiologist and that it's clinically justified, like we do all our exams. The clinical justification, obviously the radiologist approving it is important for this. So if they've approved it, we do a LARA. But, and another important fact to make is that if it's ordered by like a JMO or a registrar, they should talk to the consultant and get the consultant to talk to the radiologist just to prove that it is justified. You know, when you're first starting out in any sort of job, you don't have the experience that the consultant has. So that's always a good thing to do. And with, I know we don't have these options, but we will. There's options such as single source, single energy, single source, dual energy, dual source, single energy, dual source, dual energy. So there's lots of options how we can perform this Ctpa. And I'm going to speak about that throughout the rest of the talk. Only 2% of pregnant patients who have a Ctpa actually have a PE though. It's just because the doctors are like, oh, I'm worried, I'd just rather have it done so I know either way. And an interesting fact, in 1998, 80% of patients suspected of having a PE had a VQ scan. So obviously that's changed now with the advent of multi-detector Ctpa protocols. So with my review, as I said, I reviewed 32 studies. These graphs took me a long time and a lot of maths to figure out, but pretty much what we can see is the CTDI has an average of 8.9, and to figure all this stuff out, so you need to do CTDI weighted, which is a third of the peripheral dose, and 2/3 of peripheral dose, a third of central dose in a phantom, 100 ml phantom, and then to get CTDI vol, we divide that by pitch. Anyway, so, the important thing is with CTDI vol, that's a measure of the tube output, not the actual dose that they receive, which varies given their body habitus. So from that, I just got DLPs because some people would prefer to state dose in DLP. And then, so to get that, you do CTDI vol times scan length, which is everybody generally knows. And then effective dose. So to get effective dose, you times DLP by conversion weighting. And for the thorax, it's 0.017 millisieverts per milligray. And that's for a female, obviously, because they've got breast tissue, etc. It's different weighting factor than what a male would have. As I said, I did 32 studies. These were all from 2010 to 2014. So they're very relevant. And they're all done on 64 slice scanners or above. Some were like 256, but 64 was the minimum. And from all these reviews, I came up with the important factors. So important factors are KVP, reference MAS, or effective MAS. It depends if you want to let the scanner decide or if you're going to just set an empirical value. Detector collimation, injection rate, respiratory instructions, scan length, and type of fetal shielding. So with the KVP, as we know, for a diagnostic Ctpa, we require a mean attenuation over 250 Hounsfield units at all levels of pulmonary vasculature. So as long as we get down to segmental levels, subsegmental PEs aren't that clinically relevant. So as long as we get that down to the segmental level, we'll be fine. And one of the ways that we can achieve this is by reducing the KVP from 120 to 100. So on our new scanner, our protocol should be that they're all done at 100 unless it'll be a weight-based thing. Obviously, I won't be able to set that. That'll be up to Ash and Clem. But I can provide them with the information that I've received from doing all these studies. And by decreasing the KVP, why are we getting an increase in attenuation? I suppose I better ask the audience to keep you involved. No? Okay, cool. So if we decrease the KVP, so we're decreasing the mean energy of the beam. So the mean energy of the CT beam will roughly be half of what the maximum KVP set is, same as X-ray. So if we're decreasing it from 120 to 100, we're decreasing the mean energy from 60 to 50. And that's important because the K edge of iodine is 33.2 kilo electron volts off memory. So any number, so the photon energy, if it's closer to the K edge, it's more likely to have a photoelectric effect occur, which is what we want. We don't want Compton scattering because that's useless information. So that's why decreasing the KV, it would be even better to decrease it to 80, because obviously 40 is close to 33.2, but you've got to be pretty tiny to do that. Otherwise you get photon starvation, you don't have enough information reaching the detectors, image is going to be too noisy. So a lot of people worry, oh my God, like if you don't have a lot of experience with the scanner or doing them, or is the radiologist going to bite my head off? Am I going to get in trouble? Have I stuffed up? Have I got to do the exam again? No, there will be a 19% increase in noise, but they're barely able to detect this because the decrease in signal to noise ratio is compensated by the increase in contrast noise ratio. And the only way that a radiologist will really be able to tell what you've done is if they read the top corner of the scan where it says your KV, MA, etc., etc. So do they really read that? I don't know. I doubt it, but we could always ask them. But as long as the image quality is going to be fine, they're not going to bother. They're not going to come chase you, oh, you changed this. So by patients less than 50 kilos, as I said, decreasing it to 80 kV, you get another increase of 118 Hounsfield units. So that's quite significant. So if you're going from 120 to 80 for a person less than 50 kilos, you're going to get a 214 increase in attenuation in my main pulmonary arteries. So, you know, that's a huge increase. I sort of answered this question for you guys, but and by decreasing that 80, you're not going to get an increase in noise, as I've shown through that data. As I said, over 78 kilos don't reduce the KV. I've already given you the answer. Obviously, the amount of photons reaching the detector isn't enough, and then you'll get non-diagnostic levels. So, you know, the noise is going to be too noisy. So KVP and maternal dose, reducing it from 120 to 100, how much theoretically would we be reducing the dose, the maternal dose? Nope, okay, cool. If we go back to physics, the dose received is directly proportional to KV squared. So if you use D equals Fx, which is your dose equation, X always equals CV squared Q, which is like the system constant, the tube voltage, and the MAS. So by doing these equations, we get a 31% reduction, which is quite significant. Obviously, we're not changing our MA pitch, everything's staying constant except we're dropping the KV. There's going to be a 31% decrease. And then if we drop it from 120 to 80, it's going to be 66% using those equations again, obviously. So I can do those equations one day if you want, that's fine. I had to do them for my talk and more than happy to do that. So KVP versus fetal dose. Okay, so say we reduce it from 120 to 100, what do we think? Is the fetal dose going to be, is there going to be a bigger difference compared to maternal, or is there going to be less? What are we thinking? This is going to be a bigger saving. So we're going to get a 50% saving for a fetal dose. And if we're decreasing it from 120 to 80, we're going to get a 92% decrease in dose, that's huge. We're getting it down to 8% of the initial dose. And this was pretty unexpected, to be honest, from all the studies that were done with phantoms, etc. And it was obviously, if you've got a lower KV, the photons obviously aren't going to be able to transmit through the body. All the dose that the fetus receives is internal scatter, so they're not getting the same distance in the internal scatter, therefore they're not going down to the fetus. So that's why you're seeing those huge reductions, which, you know, is quite astounding. So reference MAS, as everybody knows, is directly proportional to dose. So by limiting the reference MAS, we can really reduce the dose of the scan. So when is this particularly important? When might we be worried about that, you know, oh, we really do need to change the MAS, we do have a big say. What might we have changed, and what might result that we don't want?
What's the question again?
So say we're reducing, so say, when is it really important that we determine what MAS the scanner gives, not what it actually wants to give?
do you mean when you've got like a...
If we're scanning
patient
anybody.
that, you know,
So, okay.
significantly less than your mean weight range?
So if we reduce the KV, the scanner's going to want to increase the MAS. So it's going to want to bump it up. It's directly proportional, whereas KV is only 2 KV squared.
Yeah.
So if we were to drop the KV, say, from 120 to 80, the scanner's going to go, oh, I want to give it the full MAS I can give it. I'm going to ramp up. So we're not actually saving them dose.
Yeah.
So if we were to change the KVP, we also have to limit how much MAS the scanner can give. Otherwise, it's just going to want to compensate. It doesn't care about dose. In its head, it's just worried about image quality.
Yeah.
So with the Toshiba, which is the one I programmed in Goulburn, and it'll have the same principle with our new one, it will go off your scanogram. So it will always do 2 scanos, and then it'll modulate in the X, Y, and the Z plane. And obviously, if we are decreasing the KV, it will think that the standard deviation in the scanos has gone up. So it's going to be like, oh, I'm going to give more dose to bring it back down. So that's an important thing that we need to think of. If we start playing with how the scanner's protocols are, we need to really, decrease the reference MAS. Yeah. And I've got tables that are weight-based that tell you what you need. Yeah, so if I've given them that, I'm not going to get an undiagnostic study. You can have that confidence, which is important for us. Yeah, because you don't want to, oh my God. Like I've done a few paediatric heads here recently, and I've dropped it down quite a bit from what was said on the scanner. And actually a parent rang up again on the weekend and asked the paediatrician, oh my God, what dose did my kid get? And they rang me, and I just happened to be working in CT, and I said, I reduced that right down, I said, talk to Michael if you're worried, but, it wasn't well above the limits like the standard, so that was good. Anyway, so detector collimation, it affects your reference MAS as well, because it's proportional to the noise ratio of the image. And thinner slices, you also get overbeaming. So by overbeaming, the more rotations you're going to have, the more overbeaming you're going to have. So overbeaming is, so you've got, it comes out like this out of the detector. We've got this much detectors. Overbeaming is the stuff that's just hitting either side of the detectors. It's not getting used, but still goes through the patient, obviously. So the more rotations it has to do, the greater percentage of overbeaming has contributed to the dose of the patient. So if you increase your collimation, you don't have to do as many turns. You can decrease the dose due to overbeaming. So that's what I mean by overbeaming. And peripheral emboli aren't really that important, which is what I said. Subsegmental level, there's only ever 2 to 7% of CTPAs just have a subsegmental PE. If there's subsegmental, there's normally a larger one that they'll pick up anyway. And as I said, only 2% of CTPAs that a pregnant patient has actually are positive. So it's like 2% of 2%, which is, barely significant. Do you clinically treat a subsegmental PE? Probably not, but ultimately that's the doctor's decision to make, not mine or not ours. So yeah, that's all interesting. And by increasing collimation, the signal to noise ratio will increase by the square root of the thickness ratio. So what do you mean by that, Andrew? Most detector collimations are preset at 0.5, which is the thinnest we can get. So we can reduce dose by 41% by increasing the detector collimation to 1% to achieve the same signal to noise ratio. Another way that we could do this and keep our finer detector collimation for our MPRs, etc., would be to increase the, they call it the user level of noise. So you could, that's on the Tosh, there's like low, standard, high, very high. So you can just pick low, and then it'll allow more noises to be in the image. Therefore, you're still reducing the dose. But if you're confident, you can start playing with collimation. Not until you've been doing it for quite a while would I suggest doing this, but changing KV, reference MAS, that's quite easy to do. You don't have to worry too much about that. Yeah, so that's all that explained. Overbeaming, as I said, it's got to do with the penumbra and falling outside the active detector area. And for your first image, this is interesting. To get the data required to make images, you need 180-degree rotation plus the fan beam angle. So if it's 40 degrees, you need 180 plus 40. You need 220 of a roll of the gantry. So not the full 360, you only need 220, so it doesn't need a full turn. But anyway, you know what I'm saying. And with a 64 slice scanner and a beam width of 40 millimeters, the DLP can be increased 30% if you're only scanning 20 centimeters due to overbeaming. So it can be quite significant. A lot of the new detectors and new scanners have this thing that it collimates it until it hits the area that you actually need. So that's interesting. They're called, what are they called? Dynamic collimation is what it's called. Yeah. So another factor that we can play with if we feel confident is pitch. It affects reference MAS as it determines the effective MAS. We all know effective MAS is reference MAS divided by pitch. So if you increase your pitch, obviously, you know, you're decreasing your dose. The problem with pitch is inversely proportional to maternal dose, which is good. The bad thing is that, as I said, you need your 180 plus the beam angle of the scanner. So if you're increasing your pitch, it's going to lengthen the scan to allow for adequate reconstruction. So it's actually going lower to the fetus. So you get what I'm saying? Because the helix is so wide, to get that extra, you know, 220 with the 40 degree beam angle, it's going to go a bit further down towards the fetus, which is, you know, the biggest dose increase is how close you're scanning to that fetus because of the internal scatter photons. So that's something important to remember. So with the TOSH, which is what I was using, if you're using 32 millimeters, which is what we did because it was 0.5 times 64, by a half rotation is going to be extra 16 millimeters closer to the fetus. So that can quite increase the dose. The other thing, actually, if you increase the pitch too high, it affects the slice sensitivity profile, which can give you artifacts, and obviously it decreases spatial resolution the wider that helix is getting. So this is my recommendations. The simplest method, you know, you're not going to remember everything to do with the scanner. The simplest method is just if you've got a chart like this. Okay, so my patient's 65 kilos. Oh, yep, I'm using single energy, righto. So it's 100 and 120. I can just set that reference MAS. Doesn't matter what your pitch and that is. Obviously, you would want it close to 1. Just so you're decreasing the fetal dose. But the thing is, an advantage of increasing the pitch for the mother is that they don't have to hold their breath as long. Obviously, it's a quicker scan, but, you know, mother holding breath, dose to baby, you know, it's one of those things I'd probably prefer to decrease the dose to the baby, but that's just my clinical decision to make, and it'd be your clinical decision to make, whatever you decide. As you can see with these reference MASs, over 90 kilos, you know, I nearly advocate going for a VQ scan. Obviously it depends on how good your scanner is. On the old 16s, I wouldn't do 16 slices, and the old 4 slice I used to work on, I wouldn't bother doing a pregnant patient, go for a VQ. On 64, yeah, I'd probably, do it. On the new scanner, I'd say I'd nearly definitely do it. I wouldn't bother about the VQ. But as you can see, these reference MASs are a lot smaller than what our scanner gives. You know, obviously our scanner's got an older reconstruction technique, whereas the new scanner will have ADAR and stuff like that, which is like algorithms that it uses to process the information to decrease noise. So we're going to get big savings there. And yeah, it's got QDS and ADAR, and they're just technical terms. They're basically saying we're reducing the noise in the images, so less dose, they're still diagnostic. So this is for the dual energy acquisitions. As I said, it's not up to me if we do dual source or not. The big thing about dual source is that you can get perfusion characteristics of the lungs. Are the radiologists going to use it? Is it going to be beneficial for their reporting? Are the clinicians going to want it? I don't know. That's not my decision to make. Whoever's the senior's got to decide these things, and with obviously consultation with the radiologist. And you know, seeing those levels, they seem quite low, but this is like a confidence builder for everybody in the room. So this study, it shows that diagnostic images can be obtained at 100 and 120 kV with a 1 millimeter slice thickness, and the effective MAS of 87. So that's, if we go back, I don't know how to, oh yeah, so if we go back, that's a lot less than what I'm recommending, like 120, you know, 1.5 if they're below, you know, 50 kilos. If they're below 50 kilos, they're pretty much a kid. So this person higher has done it at 87. And this is the images, obviously, and you know, the diagnostic, which is good for the radiographer who done this. So you get excellent visualization down to a subsegmental level, which is what you can see. So on this side, it is 120 kV. On the other side, it's 100 kV. The thing is, however, that these study populations, as you can see, they only have a perpendicular skin to anterior rib distance of 3 centimetres, plus or minus 1.8 centimetres. So obviously your pregnant population are going to be carrying a bit more weight. They put on weight during pregnancy. So, these could be, like tiny Asians or elderly people. I don't know what they are, but obviously you can tell that they don't have a big body habitus. Yeah. So standard Ctpa protocols are unreliable for 25.5% of patients. Why? Why? How are they different to a normal person, myself having a Ctpa? What do we think?
You've got all that pressure of the pregnant belly and everything, pushing up on the lungs, and they can be more short of breath.
Yep.
They can also be more nervous.
Yep.
Cardiac dynamics.
Yeah. Yep. So they're all that's all right. Obviously, when you've got a baby in there, you're going to change quite dramatically. So as I was saying before, the physiological changes. And by what I mean by that is you get a 50% increase in plasma volume. Obviously, there's more blood pumping around, more tissue to supply. You'll also get increased cardiac output. Obviously, if there's more blood, it needs to get round where it needs to get round. And you get an increase in heart rate and total vascular resistance. And as Jody said, you get increased pressure on the inferior vena cava. So which precept protocol should be altered to reduce this rate? Obviously, we've talked about KVP, etc. But, this is due to the physiological changes. What should we be changing? And that is injection rate and respiratory instruction. Obviously, I said pressure on the IVC and all the blood characteristics, so plasma volume, increased cardiac output, etc. So, as I said, you increase by 25% weight when you have a kid. This leads to dilution of the contrast bolus, just like if I advocate, and I do it now, if I've got a big patient that needs a CT, the cannula can take it, it's going in at 6 mils a second, because I know that I'm wasting my time otherwise. And if anybody was to ever argue the point with me, I'd be quite happy to have an in-depth conversation regarding it. And so by doing this, obviously it's more dilute, and it's dilute by 112 Hounsfield units. So say, your scanner, you're getting roughly 300, which is probably the average that I've seen on a lot of CTPAs on this through packs. If we're pregnant, we're decreasing it by 112, we're getting down to 200. That's not a diagnostic study, so why do it? So by increasing the injection rate, this can be used to combat this issue. So obviously we're increasing it about 50%. Because the cardiac output's increased about 50% in the second trimester due to increased heart rate and stroke volume. Obviously your heart, you get that hypertrophy of your cardiac chambers, and the heart rate in the first trimester is increased to increase the stroke volume before the hypertrophy of the cardiac chambers. So the scan takes 4.5 to 5.7 seconds on a 64 slice scanner normally. And what I always advocate is giving it a saline push. When we get the new scanner, we'll probably be doing all CTPAs, well we should be, doing them with 50 mils of contrast and a saline push behind it. You should never use 100 mils, especially on the quicker scanners. You could nearly even do them at 30, but we'll probably start, again, not my decision to make, but they'll probably start at say 70 with saline, just to get people more used to it, and then it should drop back down to 50. I was doing all mine at 50 in Goulburn with a saline push on a 64 slice scanner, so the new one's more than capable. So yeah, what else was I going to say? Obviously, if you've got an increased injection rate, you're going to have a faster time of arrival, and with the saline push, you're going to have a prolonged duration of the contrast plateau, so therefore you're less likely to miss it, and you wouldn't want to miss it. So the next study is if pregnant patients are instructed to take a full inspiration, they're going to Valsalva on 12 to 39%. I know that's a broad range, but that's encompassing the 32 studies that I looked at. Its higher prevalence is due to physiological stress factors. And if they're really anxious, they might be, like take a real big breath because they're anxious. And also when you're pregnant, the heart's pumping more blood, the hypertrophy of the cardiac chambers, you're also going to have an increase in the tidal volume of your, obviously the blood needs to be oxygenated more, the body's making all these changes that, you really need to get that tissue to like the blood to perfuse to all the relevant tissues. So various techniques have been reported to reduce the risk of Valsalva, such as shallow inspiration, expiration, shallow breathing. So what is the industry standard? Different places do different things. Shallow inspiration would probably be, in my opinion, the most effective breathing command, as it reduces the risk of Valsalva while allowing an uncrowded view of the lung parenchyma and pulmonary vasculature. Fetal dose is also exponentially decreased because the distance between the scan and the fetus, that's an exponential relationship. So by increasing it, you're greatly reducing the dose. As we know, exponential graphs go up like that. And the really important thing about this is I practice it with all Ctpas that I do now. As I was telling T this morning, I go in there and I go, because a lot of them are used to having the chest x-ray before, so they're like, they want to get the really big breath, and half an hour later they come for this CT and they're still, I've got to do as big a breath as I can. So I go in there and I practice with them and just a little, and hold it. So it's barely even a breath. So you mightn't even call it a breath. You might just say, just hold whatever rate, part of inspiration. If it's expiration, that's not good either, because if you try to do this, so if you go and hold it out, like I'm gasping for air, I need air, so that's probably the worst thing you can do is the expiration, because if you try it yourself, try it at home later, whatever, if you're breathing out, you can hold it a lot more easily with a small inspiration than an expiration, because you're like, I need air, I need air, I need air. So anyway, that's just my opinion. Third trimester patients, however, if they're really struggling to breathe, you can just do it with shallow inspiration, which is what a lot of people do here for all trimesters. But if you're really, just shallow breathe, and you'll get a slight reduction in image quality, but obviously it's mainly going to be subsegmental region, which isn't that important for the detection of PEs in any sort of population. So sorry it's going for so long. The scan length is also an important factor. Obviously, when I used to use the 4-slice scanner, we used to cut off the apices, cut off all the diaphragms. It was just here to here. Don't worry about all this. But now that more detectors are available, obviously everyone's like, oh, yep, we'll just cover the whole thorax. So all these 32 studies show that the average scan length was 31.84 centimetres. However, the pulmonary arteries of interest is central, segmental and subsegmental are only located between the aortic arch and the lowest hemidiaphragm. So anything above that, there's no point scanning it unless you're looking for, say, a lesion or something else, tuberculosis in their apices, etc. But with pregnant patients, they're generally younger, so they don't have as many comorbidities, etc. So the incidental findings aren't going to be as high as if we're Ctpa on, say, an 80 or 90-year-old. Okay, they might have a small cell carcinoma, or these people are generally very healthy. The main thing that they're looking for is the PE. Not saying that, that there isn't any incidental findings. There might be, but normally if you cover it there to there, you're going to have like pneumonias and stuff like that covered. And they should pick that up on a chest x-ray anyway. So one of the studies by Atley showed that all you need is an 18 centimetre scan length, and that will capture all the pulmonary emboli that are detectable, and this should be centered 4 centimetres above the carina. As you can see, they've got lowest hemidiaphragm, they're well above the arch, so that's fine. Scan length is linearly related to maternal dose, so by decreasing it to 18 from, I think it was 34, from 31.84, we're reducing the DLP by 43%. However, if you were to use automatic tube modulation in all 3 planes, obviously your attenuation in the mid-thorax is a lot less than the lower and upper thorax, so we may even see a bigger than that linear 43% reduction, because you've got your shoulders to go through, you've got your abdomen to go through. Here there's very high inherent contrast, there's not a lot attenuating the beam, so we could actually probably, if we did studies on an actual person, you'd probably see it reduce more than that 43%. The bonus dose reduction is because the fetal dose is exponentially proportional to the distance between the fetus and the scan field. That's what I was talking about before. So the fetus to the costophrenic angles in first, second, and third trimesters is on average 20, 10, and 1.5 centimetres away. And to the hemidiaphragm, it's 27.5 to 17 to 7.5. So to the costophrenic angle compared to the hemidiaphragm, there's quite a big difference. So we can do huge dose savings by just that lowest hemidiaphragm, not the costophrenic angle, which is what this graph shows. A reduced scan length from 6 centimeters above aortic arch to the lowest hemidiaphragm is what I recommend. You know, you're not going to get any radiologists complain why didn't in Goulburn, we might hear, but that's something that you'd have to discuss obviously with the radiologist before you did the scan. Look, are you happy if I just do from here to here? Their decision, not mine, unless we had a written protocol regarding it. Not only is the dose reduction, you know, obviously not only is the dose reduced, but we're also reducing the probability of respiratory artifacts. We're scanning a smaller volume, they don't have to hold their breath as long. As I was saying, incidental findings are less likely in a younger population. Also, this is interesting, especially beneficial for pregnant patients, is if you scan craniocaudally direction, the lower lobular arteries are most likely to contain PEs, which is the same with anybody. So fetal shielding, okay, so am I going to put a shield on this lady? It's all internal scatter. I don't know, should I do it? Is it going to increase the pressure on the inferior vena cava, but it's going to make her feel a bit better? You know, all these things are going through your head. Is it going to actually reduce the dose, or is internal scatter, the internal photon's going to hit the gown and then come back towards the fetus? Oh, I don't know, I'm getting a bit nervous about this all, you know. So most radiographers don't place lead over the patient's abdomen because it increases their discomfort and but it also, because it decreases their discomfort and they have concerns about that internal secondary scatter, which I was talking about. The studies have shown, however, if you place lead around the entire abdomen, that's the most effective way to reduce dose. It also decreases patient anxiety, like, oh, my baby's covered, they've got lead over them, you know, that's good, you know, I feel better about having this done. If you only do it over the top, obviously the scanner's, you know, rotating 360, you're only going to half the dose that you could be halving. But if the gown won't do up over them, obviously cover anteriorly more than posteriorly because the fetus is more anterior. It's just common sense sort of stuff. But if you're like rushing to get it done or a bit nervous, it's stuff you mightn't think of. And internal dose levels are always higher than surface dose levels, no matter what you're scanning, what patient, if it's not in the primary beam. So more dose through internal scatter than external scatter. So what can the literature tell us? It's a bit hard to read, sorry. I should have dulled that a bit, the background a bit more. But external scatter radiation can be reduced by 75% when lead shielding is wrapped around the patient's entire abdomen. This equates to a 73% reduction in fetal dose when 120 kVp is used, and scanning to the costophrenic angles. Obviously, I wouldn't scan to the costophrenic angles, but in this one study they did. But when using 100 kV and scanning to the lowest hemidiaphragm, which is what I recommend, an 82% reduction, 70% and 68% reduction can be achieved in the first, second and third trimesters. So if the patient's like, oh, how many milligray is my fetus receiving, etc., I've got charts there that you can give them a definite answer from the reference MAS used, the KV, but you've also got to know the distance between the fetus and the end of the scan field, and it's very complex, and if you give it to them, then, you know, how reliable it's going to be. I'd more say, look, this is what roughly you're getting, this equates to this. So at the end of the talk here, I've equated everything back to days of background radiation from radon, cosmic radiation, etc. And they can understand it more. Milligray, millisieverts, they'll be like, I don't know. Like a bit like the doctor the other day about that head. I said, oh, they got this many milligray. It was like this CTDI, and I don't know what you're talking about. You just tell me, was it low or was it high? You know, they don't know. So if the doctor's not going to be able to understand it, how can the patient, is my thinking on it. So lead aprons decrease the distance from the scan field to the fetus from an exponential to a linear relationship as well. Which is important. You know, obviously that compared to that, you're going to get a massive dose reduction. At 100 kVp, by increasing the lead thickness over 0.5, like some people might go, oh, I'll double up this lead apron over them, but it's twice as thick, it'll attenuate more. There's no point over 0.35 millimeters because you're only going to reduce it by 7% anyway. And then you've got more pressure on that IVC, more likely stuffing up the study, and you're going to increase the dose because you're going to have to do it again. So all lead gowns have to be a 0.35 millimeter equivalent, so I'd just use that. And if they feel as though it's too heavy and, oh, you know, it's putting a lot of pressure on my tummy, you could always put something to prop it up, but I'd probably just get rid of it. You know, it's just one of those difficult decisions to make, but I'd probably get rid of it, and I'd just explain to them all this information that I know, and if you know what you're talking about, that's going to relieve sort of a fair bit of their anxiety, and you know, and that builds rapport and builds trust, you know. So fetal dose, using the upper limits of my recommendations, and using unendorsed practices such as scanning to the crosstophrenic angles and not utilising lead shielding, it's only 0.8 to plus or minus 0.1 milligray, which is equivalent to 10 months of background radiation. So you go to the mum, all right, it's not even going to be equivalent to you walking around the street getting irradiated by cosmic rays, radon, you know, all that background stuff, sleeping next to your husband, you know, that increases radiation dose. So it's only 10 months, you know, and that's the highest it's going to be by using those, the 120 kVp and 20 reference MAS. So that's for that big person who's near 90 kilos, which, you know, we might get that here, but that's all right. And if you tell them that, that's going to relieve them a lot. And so this is the Simpsons Guide to Radiation, just to break it up a bit and just to make it a bit more funny. Sievitz gives you 3 eyes, etc. Anyway, I got laughs at that in Marimbula, that's all right. By using the dose strategies, first, second and third trimester fetal doses will be less than 0.02 milligray, 0.09 and 0.11 milligray. Obviously, the last one quoted is third trimester, you're closer to your primary beam, it's going to be the highest dose. 0.02, you know, that's nearly negligible. And obviously these levels are well below the deterministic effects. As you know, you have stochastic and deterministic effects. So deterministic, you know, like hair, all that sort of stuff, skin burns is 50 to 100 milligray. And you know what I'm saying, I just got my tongue tied. There's no threshold exists because we're using the linear non-threshold radiation model. But this model is obviously based off Hiroshima and Nagasaki, and it wasn't just X-ray radiation, it was beta particles, it was alpha particles, it was gamma rays, but they still use this just to be safe, you know. They're like, oh, we'd rather overcall it than undercall it, and that's just the way it's been. There's a new study coming out, was meant to come out this year regarding dose by those people. The United Nations Scientific Committee on Atomic Effects of Atomic Radiation. So they were meant to publish a new study this year. Obviously I wrote this talk last year, so I haven't seen if it's come out, but I'm basing it off theirs that they wrote in 2000. So due to the, and also the problem with this is there was limited amount of data regarding in utero radiation exposure. Obviously all the people who got irradiated in Nagasaki and Hiroshima weren't all pregnant. So that there's no mathematical models that are currently present to calculate fetal tissue weighting factors. Therefore, to make it simple, I've just done the effective dose and calculated the risks. So I'm saying that the entire fetus is being irradiated to the same magnitude. Therefore, 1 milligray will approximately equal 1 millisievert. However, we know different tissues have different conversion weighting factors. But just because there's no such thing, I've just made it simple and said, all right, the whole fetus is getting irradiated, even though the head or the bottom or whatever's closest to the primary beam is going to be irradiated more. Okay, so just to make that clear, hopefully there will be some models and, you know, I could redo all the data, but it wasn't available. So the International Commission on Radiation Protection says, so this is the relative risk, so excess relative risk. So excess relative risk is the epidemiological risk measured, so that it quantifies the level of any risk among persons with a given level of exposure, which exceeds the risk of the non-exposed people. So this is how much is my risk being increased compared to somebody who wasn't irradiated. And I've also done the excess absolute risk, which is the risk of cancer compared to the background risk. So it's just comparing it, background people obviously compared to if you did get it. All scientific stuff, don't worry about it, who cares? It's just I had to include it for my study, for my masters. So pretty much by decreasing the KVP, limiting the MAS and scan length, and by utilising lead shielding, an EER of 6/10,000 for third trimester and 1 in 10,000 for first trimester. These levels are equivalent to 7 and 40 days of background radiation. So don't stress. So obviously, if it's first trimester, you're limiting it by all the things I've done that I've told you to do. They're only going to get equivalent to 7 days of background radiation. That's a week, like you know, that's nothing. And third trimester is obviously 40 days. But if you don't decrease all those things, you're going to get that 10-month one, which, you know, mightn't be that significant either. That's, you know, your decision to make. Another thing some parents ask me, because I've done quite a few CTPAs on pregnant people, is, oh, what are you injecting me with? Is that going to hurt my baby? Like, you know, oh, I'm really worried about this. I don't want to have that die. I just want the CT. But obviously, IV contrast, you know, their concerns do have a bit of merit. IV contrast can cross to the placenta and pass into fetal circulation. A lot of people don't know that, but that's something that does happen. However, it has not been shown to affect the fetus in any animal studies. Obviously, they haven't just been giving it to people and seeing what happens. But with all the animal studies, it's safe. But because it hasn't been tested on human, the FDA classes it as a Class B drug, which means only give it when necessary. Obviously, if you're doing a CTPA, it's necessary, we can give it, that's fine. The problem with it is, the theoretical problem is that it can cause hypothyroidism, but all the pregnant patients that have had the CTPAs and had the fetus, obviously they do a thyroid test within the first life. That's just a standard thing. They're going to pick up if there is an issue. They haven't picked up any issues yet that they can relate to contrast, so therefore the FDA is deeming it safe. Yeah, so I wouldn't worry about it at all. And that is the end of my talk. Sorry it went for so long.